CLL has an enormous amount of interesting data presented at this meeting. What we will focus on in this presentation will be one of the challenges to chemoimmunotherapy that has been presented with a novel drug, ibrutinib, in the plenary session, and we will discuss some immunotherapeutic approaches that may come up to solve problems specifically for high-risk patients. The Alliance trial was presented in the plenary session with a parallel publication in New England Journal of Medicine, and is a large randomized trial that compares 3 arms. It asks the question whether ibrutinib plus minus rituximab would be a better first-line therapy option for medically non-fit patients that would normally be treated with bendamustine rituximab combinations. And this combination is a standard treatment for a lot of people at the current moment, and the challenge is based on well-balanced randomization that the progression-free survival is significantly and probably meaningfully better in the ibrutinib-containing arms. Based on previous experiences with combinations with CD20 antibodies and ibrutinib, the randomization with ibrutinib plus minus rituximab shows no benefit for the antibody combination, so basically there's absolutely no difference there. The trial goes on to show that there is no overall survival benefit at the current follow-up, which is interesting and probably limits the current sort of impact the study will have immediately on the type of treatments that people will receive, specifically since the trial also has high-risk patients with deletion 17p included, and the follow-up is probably too short for an overall survival benefit, but it does not suggest that there's an immediate sort of call to action that we have to switch everyone to a frontline durable treatment that will not allow treatment-free intervals. There is an unexplained higher rate of unexplained death in the ibrutinib arms that will potentially have something to do with the fact that there's no overall survival benefit. I think that's an important issue that has not been completely resolved in the discussion up to now. These are really important results. I'm not sure they're completely practice-changing at the moment. They line up with the Illuminate study that has been presented, where we also see a very significant difference in progression-free survival, always keeping in mind that we compare a limited duration chemoimmunotherapy with a prolonged maintenance strategy. So it's not clear whether these sort of initial benefits in progression-free survival can be compensated by crossover, which is reported in both trials. And I think we need further follow-up to be clear about the impact of the long-term treatment in terms of toxicity, to be able to delineate the impact of these trials. It is, however, clear that we have very potent strategies for first line, and the conference has shown a lot of potential combinations that would potentially allow us to stop treatment at some point. So the future for chemoimmunotherapy combinations certainly doesn't look good, but I think they're not dead yet. CLL has initially been relatively disappointing in terms of the results from CAR-T cells, but this meeting has a number of abstracts showing that combinations with ibrutinib, which is not necessarily just used for control of disease, but potentially with its abilities to modify T-cell responses, may be an interesting strategy to follow. There's an abstract from Seattle, abstract 299, which has shown that you can actually generate viable and very good CAR T-cell products with continuing ibrutinib therapy throughout the whole period, and that has shown very high response rates, very encouraging response rates. However, all of these trials have a certain mixture of severe toxicities that need to be taken into account in order to be able to place these strategies in the right spot in the CLL treatment algorithms. For the moment, these are experimental indications, but I think there's a good signal that high-risk patients that will eventually relapse on all the targeted drugs that we have a reason to be hopeful about their outcome, because there's something that will come up for them over the next couple of years.